We are live, sir. Please start.
Hello, good evening, everyone. It's a great pleasure and honor to welcome you all for the day two of ASCO 2020, Learning from ASCO 2024 deep dive on GI cancer. Uh, Unfortunately, Dr. Vamshi is traveling, and I think he'll be able to join by in next half an hour's time. So, so we are going to start the session one, which is like on the hepatocellular carcinoma. To do the honors, the first speaker, it's a pleasure to welcome and invite Dr. Krishna Chaitanya. Good evening to you, sir. Sir is a consultant medical oncologist at the prestigious Somaya Hospital at Hyderabad. Good evening, Dr. Krishna Chaitanya. And Dr. Krishna is going to throw light on the role of atezolizumab and bevacizumab in metastatic hepatocellular carcinoma. Once again, very good evening and warm welcome for this exciting session. Over to you, Dr. Krishna, for your talk, please.
Thank you so much for that kind introduction. Am I audible?
Yes, sir. Please
Yes.
continue.
Yeah, excellent. Thank you. So I at the outset, I would like to thank the organizers, Vamshi sir, for giving me this opportunity. So let me start with today's topic on the HCC, that is the atezo-bev combination therapy. So let me start the topic. So when you come to the liver cancer, the incidence, you have 4%, of all the cancer diagnosis as liver cancer, and this will account for 8% of the mortality. The liver cancers will account for the 8% of the mortality when you take the total cancer mortality. And this is most commonly seen in the developing region. So you can see 75% of the cases are seen in the developing regions, and men will have threefold higher risk compared to the females. And histology, the hepatocellular carcinoma is the most common. 90% of the cases it's HCC, whereas 10% maybe it can be a cholangio, angiosarcoma, or a hepatoblastoma. But adeno HCC is the most common thing. And what is the causes for developing HCC? Basically, the cirrhosis. Cirrhosis is the 80 to 90% of the cases. HCC arise from the cirrhosis. Maybe the cirrhosis, the causes are again, it can be a viral, it can be alcohol, NASH, or any toxins, which will lead to chronic hepatitis, convert into cirrhosis. Then it will develop into early HCC followed by advanced HCC. Only 10 to 20% of the HCC do not arise from the cirrhotic liver. When you come to India again, it's the 8th most common cancer causing the mortality. And you can see the 5-year prevalence rate is only 2.8. That means there is a grave unmet need in this cancer to have the better treatment options. And majority of the Indians are diagnosed in the advanced stage, and the 5-year survival is only 2.3%. And when you take the current TKIs available, it gives a median overall survival of 1 year. And when you take the combination of atezo-bev, it has a superior clinical outcome compared to the TKIs, and as well as the good safety profile. This is the landscape of the treatment for HCC. In 2007, it was sorafenib. Now, after 2017, you have multiple options. In the first one would be the atezo-bev combination as a preferred option, and the other TKIs are also there. And as well as in the second line, you have other TKIs and the immunotherapy. And I'm sorry if you have any background, if you are getting any background noise, construction is going on nearby. I'm sorry for that. So let us see the rationale for combination of atezo-bev in the treatment of HCC. We know that the HCC has a very good immune system mediated response from the body itself to the HCC. So there is an immune mediated anti-tumor activity for the HCC, and which we have seen in some cases where spontaneous regression may occur. So that is the concept behind it. And 50% of the HCC, more than 50% of the liver cancers, they'll have a very good infiltrating tumor cells in the tumor. And HCC also will have many markers where we can use the immune checkpoint inhibitors. So the cancer immunity cycle is the trafficking T cells, they'll go to the tumor. In the recognition of the cancer cells by the T cells, they kill the cancer cells, release the antigens. Then these antigens are presented to the dendritic cells, and in turn, recruiting the T cells. So it is a cancer immunity cycle. The cancer cells are destroyed by the T cells. Again, they're presenting the antigens to the new immune cells, forming again the T cells coming and attacking the cancer cells. So this is the basis for the immune escape and the immune mediated cancer kill by the T cells. So when you combine both the checkpoint inhibitors and the VEGF, how these will help each other. So bevacizumab is an anti-angiogenic agent which also has a additional immunomodulatory capacity. That means the bevacizumab will increase the normalize the tumor vasculature, increase the T cell infiltration into the tumor, and it reduces the immune suppressive T regulator cells in the tumor. It promotes the dendritic cell maturation. So finally, it is helping the T cells to have more, infiltration into the tumor and attacking the cancer cells. Whereas atezolizumab, it will promote the T cell activation. So it is like complementary to each other, both the drugs. That is the reason how we can add both of them. The basis for this, regimen would be the IAM-BRAVE 150 trial. It is a phase 3 trial where they compared the combination of atezo-bev with the sorafenib. Atezo is given to 115 mg per kg of bev. It's a 2:1 open label study. Locally advanced or metastatic or unresectable HCC, which is given until the toxicity or the proven benefit. Stratification factors would be the region, ECOG performance status, the macrovascular invasion, and the extrahepatic disease, and the baseline AFP. So these are the stratification factors. And we have the primary endpoints as overall survival and progression-free survival. So in this study, we can see the baseline characteristics. Age is around 60 in both the arms, and they had Asian and the rest of the world, Asian population of around 40%, and rest of the world at 60. Good performance status. All of them belong to childhood A, and majority of them are BCLC, that is advanced stage. And 70% had a viral etiology, and non-viral was seen in 30% of cases. AFP more than 400 in almost 40% of the cases. Almost 3/4 of them had a extrahepatic disease or the macrovascular invasion. So in this study, they could, we can make out the progression-free survival. You can see the median PFS is 6.8 in the combination arm. It is around 4.3 in the sorafenib. You can see the early separation of the curves, and it's been consistently maintained, giving the benefit of this combination. And the follow-up systemic therapy, when you take the follow-up, almost like 1/3 of them received the more than one systemic therapy on progression with atezo-bev, whereas in the TKI arm, more than 50% received the second-line therapies. And the TKIs all received, 30% of them received immunotherapy in the second line or the third line. Whereas the atezo-bev combination, 1/3 of them received the TKIs in the later lines of therapy. So this will impact the overall survival also. So in this, the co-primary endpoint of overall survival, you can see the initial estimation, it was not reachable for the combination, 13.2 for the TKI arm. In the updated overall survival, you can see 19 months for the combination and 13 months for the TKI. And you can see the same, like, early separation of the curves, and it has been maintained throughout the follow-up, almost like 3 years of follow-up. We can see around 19 months versus 13 months with a hazard ratio of 0.6. So this gives, clear picture that the combination is superior to the TKIs. And in the subgroup analysis, you can see all of them benefited except for the early stage disease, that is BCLC B stage, and the non-viral causes. So these are the two subgroups which did not benefit much with the combination compared to the TKI. Otherwise, all others have benefited with the combination. And coming to the response rates, it's almost like 3 times. The 12 versus 27, more than 2 times the response rates. And they have a CR, and most of them had a stable disease, and around these 27% response rates are both CR and PR, both complete and partial responses. 50% of them had the stable disease. So this is much superior to compare to with a significant p-value compared to the TKI sorafenib. And the updated response rates, it is 10 versus 30. That is 3 times more the responses compared to the TKI. And the median duration of response, it's 1.5 years. Here, it's around 15 months in the TKI arm. So as the, when you come to the safety summary, all of them had some kind of adverse events. and almost more than 50% in both the arms had a grade 3 or 4 adverse events. And the discontinuation rates you can see around 15 versus 10%. Yes. So when you come to the side effect profile, most common the hypertension and the proteinuria were more common in the combination arm, whereas diarrhea and the HFS were common in the TKI arm. And we are worried about the bleeding in HCC because of the varices and all. So when you take the cross comparison between the trials, the REFLECT and DIAM-WAVE with various agents, lenvatinib, sorafenib, and versus the combination, you can see the grade 3 and 4, the bleeding events are almost like similar, 4, 4, 6, and 6, almost similar. And they have excluded the high-risk people who can bleed, they have excluded in the analysis. And the grade 3, 4 in the low-risk people is almost same between both the arms. And the bleeding events with these systemic therapies were typically low in grade and unrelated to varices. You can see the other causes for the bleeding, epistaxis, which is the most common in the combination, whereas it is seen around 4.5% in the sorafenib arm. And the variceal bleeds and all is just little higher compared to the TKI, but it's very less. The numbers are very less. It's just 1.2 here, 1.3, 2 versus 1.9. So it is like very minimal change, very minimal increase in the bleeding events when you take the variceal bleed. And the hepatitis component, it is almost same between both the arms, combination versus TKI. And when you take the quality of life assessments for both the arms, the time to deterioration in the patient-reported quality of life, you can see the separation of the curves, and it is much better for the combination. This 11 months it will take for the time to deterioration in the quality of life compared to only 3.6 months in the TKI. And so perception of well-being. So again, it's a quality of life. You can see the physical functioning. It takes around more than a year to have a deterioration in the physical functioning, whereas it's only 4.9 months in the sorafenib arm. And the role functioning is also, it takes around 9 months for the deterioration in the combination versus 3.6 in the TKI. So we can see all the parameters are better for the atezo-bev combination rather than the sorafenib. And this is a systemic therapy for HCC. You have atezo-bev as the atezo-bev as the preferred agent. You have the other TKIs are also as the first line approvals, and in the second line you have other TKIs, ramucirumab, and immune checkpoint inhibitors. So this is the NCCN guidelines for HCC. You can see to easily understand whether resectable or transplantable. Resectable, you can go for resection. Transplantable, obviously transplantation. Whereas unresectable cases, if it is a transplant eligible, we go for the transplant. Otherwise, go for the loco-regional therapies. Whereas inoperable, where we can't do any transplantation, obviously we have to go for the loco-regional therapies or the systemic therapies. And in the metastatic disease, or the patient is having portal vein invasion, macrovascular invasion, nodal disease, distant metastasis, obviously we have to go for the systemic therapy. In the loco-regional therapies, when we decide, it shouldn't be having any macrovascular invasion, there shouldn't be any nodal disease or metastatic disease, and a good performance status, and Child-Pugh A and B. For them, we can go for the loco-regional therapies. So these are the systemic therapy options in advanced HCC according to the ASCO guidelines, what we have just discussed. And whereas the ESMO guidelines, you can see it's based on the BCLC staging. Very early stage, that is 0 or A, you have options for resection, ablation, or the transplantation. Whereas the stage B, that means it's a multinodular disease without macrovascular invasion or the nodal disease, you have an option for the transplant and as well as the loco-regional therapies. Whereas advanced disease, where macrovascular invasion is there, nodal or the distant metastatic disease, Child-Pugh A or B, and ECOG performance status up to 2, where you can prefer the systemic therapy. In that, again, atezo-bev is the preferred therapy compared to the TKIs. To conclude, the combination of atezo and bev has demonstrated efficacy compared to the sorafenib with a good overall survival and the PFS benefit with the hazard ratios of 0.6. And it has a very good patient-reported quality of life compared to the TKIs. And this phase 3 data has given us highlights the benefits of targeting the multiple steps in the cancer immunity cycle. and transform the current treatment paradigm in the first line of the unresectable HCC. So with this, I would like to end and I would hand over the session to the next speaker. And thanks a lot again for giving me this opportunity.
So, thank you so much, Dr. Krishna. As always, absolutely eloquent presentations for this. Now we are moving forward, and I think from hepatocellular, now we are moving forward to the session on colorectal cancer. So once again, good evening, and it's a pleasure to welcome the moderator, Dr. Viraj Lavangia. Sir, very good evening to you. And sir is now a director for the GI Medical Oncology at the prestigious Shelby Hospital at Ahmedabad. So Dr. Viraj, sir, over to you, and now you can invite your panelists. I hope Dr. Kripa Shankar, sir, will also join in your panel. Over to you.
Thank you, Mathur Saab. Thank you, Dr. Vamshi, for having me here. Actually, I asked him, hi, we meet again, Dr. Amol, Dr. Soumya, and Dr. Krupa. Everybody. So actually, I asked him that what do you want for 4 of us?
So Dr. Krupa is Dr. Ankur right now, I guess.
Yeah, the label is changed.
Minus the beard, of course.
Yes.
Okay, so no, basically I asked Dr. Vamshi that what does he intend to bring out of this meeting? For 30-35 minutes, what do you want us 4 people to discuss? And he said that we want an on-clive peer exchange like experience. So I said, okay, we'll try our best. So what we did for this next half an hour is I've selected 5 abstracts from ASCO this year. And Dr. Soumya was there for 2 of them in the best of ASCO. We have 2 surgical abstracts, Transmet and Orchestra, that how do we use surgery in advanced colorectal cancer. And then we have 3 immunotherapy abstracts, 1 in advanced, 1 in colon, and 1 in rectal. So we'll see. What I'm going to do is I'm going to direct my panelists to speak more. Of course, I'm going to have slides open and have a particular question directed at them, and we'll see how it goes. So the first one, Dr. Soumya, I hope you remember this was my first line, and I ask you in Best of ASCO. So this is the Transmet study. We often see such kind of patients in clinic where we have liver limited but extensive disease, where we can't do RFAs and resections and microwaves. So do you think, first of all, that there was a need to evaluate and study for specific patients like this? Dr. Soumya, can you take that?
Yeah, so can you hear me?
Yes.
So actually, this kind of disease, they have a very bad outcome. And frankly speaking, such kind of CT scans definitely doesn't look operable anywhere, means to my imagination also. So this study was really this kind of a new perspective, opening of a new perspective, leaving about the transplant difficulties and all those things. But definitely the result looks kind of very unexpected.
So can you run us through that? What kind of patients you would entertain with such a strategy? We're talking about liver transplant. So what kind of patient would come into your mind that this is the patient where probably I want to consider such strategy?
Very good. First of all, a very good transplant team. Second, a very good.
Very important.
Yeah, very important. And another is very good team of the surgeons and a stringent. There were very stringent criteria. If you look at the number of the patients screened and the number of the patients that underwent finally, so there was a very stringent criteria of choosing the patients. And outside extrahepatic, there are no disease, and the primary could be resected. And no BRAF mutation, of course. Definitely very, very ultra fit patients with the proper counseling of the patient and experienced. So somebody who sees a GI kind of a GI oncology, some kind of such a kind of a scenario.
Yeah, so basically a center with a very strong GI team and a strong MDT. Dr. Krupa, I
Hi, Viraj. Hi, good to see you,
So
mate.
we meet again. So, you know, so it was not surprising that 20 of the top liver transplant countries and centers were participating, and they selected 154 initially, 150 plus patients to start with the program, but ended up with just 90 patients. It just tells you that how difficult, how stringent the criteria required must be. So how do we deal that in our hospitals where, let alone MDT, but not everybody is gifted with strong liver transplant team. So how do you see this utilized in our practice?
Absolutely. I think, this sort of reflects the challenges that we have in our real everyday practice as well. So like you said, not everybody of us are actually blessed with a strong HPBLT unit or a hepatobiliary and liver transplant unit. So I think there is definitely a referral bias there. I mean, like as far as in our everyday practice is concerned. And again, just coming back to the trial, Viraj, I just had a few, thoughts on it. First thing is, to me, we know that patients with only liver limited metastatic disease, definitely the biology is different as opposed to somebody who's got diffuse metastatic disease, number one.
True.
Again, the concept of identifying responders versus non-responders, because ideally, the trial design was such that they only took in patients who were responders, less than 3 lines, and who had like at least 3 months of disease control. So I think that's where probably you're looking at doing response adapted therapy in in colorectal cancer with liver metastasis as well. So I think that's where the trial design for me really stood out, because you're probably looking at doing response adapted therapy even in metastatic CRC.
Yeah.
So to me, yeah, it's quite fascinating. Yeah.
So that was the very good thing. Actually, Rene Adam actually had to fight with the government because these patients were given cadaver livers, right? We cannot even dream that such a patient would get listed in because liver is a commodity and a very valuable commodity. So he had to actually fight with government to make sure that these patients in a form of trial setting are allowed to be enrolled onto the list. And while they are on the list, they were given chemotherapy and made sure that they are not the PD ones. They are the stable disease or PR. So I agree. It's a very nicely thought through strategy. Amol sir, let me come to you. So, so these were the basically baseline characteristics of the patients. Some things which stand out again. So this was what I also mentioned at ASCO, best of ASCO. 20 liver nodules. I still cannot get over such a heavy liver disease burden. And, we'll come to the results in a minute. But such a patient getting a 5-year survival, do you think we would see that?
So let us understand that they have taken a very selected population. And if you see, the trial enrollment started, am I audible? I assume I'm audible.
Yes.
Yeah. So trial enrollment started in 2016 and it went up to 2020 across 20 centers. And for 5 years, it took them to find out 36 patients on the trial arm. So it was a very selected population. I'm not able to figure out why they excluded those with BRAF mutation. If anybody can know what is the wrong with the BRAF mutation. So I could not figure out any logic behind that. And at the same time, if you see, this is the trial which are in the pre-IO era, pre-MSI high era. So these patients, of course, have not received any IO drugs, no MSI testing done on them. And I'm sure, Viraj, you are the big proponent of the MSI testing, and you will give IO or double IO to those patients who are MSI high. So these are not given here. So I'm not so sure what is the relevance of this particular data now.
So there were no MSI in this case, actually.
Hello?
So no MSI were there in this.
Have they said like that? In the inclusion criteria, they have not mentioned like that.
Yeah, but at the panel discussion, somebody asked him, Dr. Rene Adam, this question. And he said there were no
so let us understand that there are no MSI high. Okay,
Yeah.
fine. Now, still, what is important is that this is a very selected population, a very highly surgery-driven population. And the important point is that I want to understand how much liver surgery did the control arm got? Because in our practice also, if those patients who are responding, as they have said, that at least more than 3 months, at least 3 months, they should have a stable disease. We attempt some sort of a liver resection. So does the control arm got any liver surgery, or they were not offered any liver surgery? So there are fallacies in the data. We would like to see the full publication. And what is important is that I'm sure you will discuss this when you discuss the curves. The curves are crossing, and they have done what is called as restricted mean survival time analysis for these curves, and the benefit is only 12.1 month. And if you see that out of those patients who got liver transplant, almost half of them required a resurgery because of a recurrence. So it is a very extensive protocol. Somebody undergoing a liver transplant, and then there is a recurrence. Then you again undergo a liver-directed surgery. These are very, very extensive treatments, and I'm also sure our patients are able to tolerate that much physically. Forget financially, but physically.
Yeah.
So I'm a bit skeptical about this data, and with a 12.6 months OS benefit with an RMST analysis. If somebody tells me that if I did transplant, if I do the second liver surgery and all these things, I'm going to get only 12.6, then I will like to have maybe some biomarker selection to figure out which of these patients probably will be more beneficial. And this is a very important slide, that how many have underwent resurgery amount of those 36 patients. In spite of having a liver transplant, 72% have a recurrence, and almost 46% have to undergo a repeat surgery. So this is a very difficult regimen to follow.
So let's discuss
some other surgery, some other surgery. It's still a GI surgery. It's still a major surgery, super major surgery. So are patients going to tolerate that in the real world? See, again, this is a French trial. And the French people are very, all good surgical trials, like for HIPEC and all, they all come from France and Netherlands. So maybe if this data comes from the other side of Atlantic, probably we will be more happy to see. But I have some reservations about this. 12.6 months OS benefit. Okay, not that great.
So let me come back to the point that you made, that yes, these patients were not without recurrences. They had recurrences, but if you see in the liver recurrence, there were virtually none, except barring one patient. And we know that in colon cancer, lung-only metastasis, which was predominant, right, 14 out of 26 patients, are far easier to manage than the other organ. So don't you think that's such a, it's like basically.
So my point here is that, my point here is that if you see here, everything is done on this arm. And what about, there is no surgical intervention at all attempted for this arm, which is not a standard practice. We also know for some oligometastatic disease responding, we attempt some liver surgery, which is not transplant, but attempt some liver surgery. So for that arm also, I'm not so sure whether the other arm has got adequate surgical thing. And
so Dr. Amol,
let us get a full paper to see all this data.
So Dr. Amol,
yeah.
So all the patients that were in the study were like this, what I'm showing you. So there were no oligometastasis.
Yeah.
It was an exclusion criteria. If you see the lower limit of number of nodules is 14, means that was the lowest with the highest.
Correct.
25.
So that is at the beginning of the treatment.
Correct.
That is at the beginning of the treatment. Then after taking 3 months of treatment, they have a stable disease. That means some of those nodules must have regressed. So there is some attempt of the local liver surgery could have been done apart from transplant, especially no surgical intervention is done on this arm. That is the control arm. It is a bit unfair.
So that bit unfair part, let's hold on to that thought, because this is an assumption that as a physician we have that.
So let us wait for the full publication. As I said, let us wait for the full publication.
Wait for me to go ahead 5 minutes forward, and I'll show you.
Please.
Why our assumption
is
wrong, because that's our next paper called Orchestra. because that's exactly answering
Yeah.
what you are, that assumption. Okay, but before we
So,
move on,
so let me put that point. You are saying that in orchestra is negative for GI surgery, but if you do liver transplant, the trial comes positive. So there is something fishy. That means if you do a big surgery, we are happy. If you do small surgery, we are not happy.
no, Dr.
Maybe
Ramukha.
we'll have
I
to
think so. We are
see the data
digressing.
in
We are
detail.
digressing. We will discuss the
Okay.
orchestra.
Let us go ahead.
In orchestra, we have multiple organs involved. Anyway, so wait.
Yep.
Let me have Dr. Soumya come in. Dr. Soumya,
Yeah.
do you think that about half of our patients, forget half, let's say 20 to 30% of our patients would be alive at 5 years with such a disease to begin with? Do you think this is practice changing? If you are gifted, your hospital is gifted with state-of-the-art liver transplant team, would you start discussing this in your MDT, such a treatment option for your patient?
So first of all, regarding the first question, that whether the outcome is good in such kind of patients with only chemotherapy, the answer is no. So usually conversion chemotherapy, what Amol sir was alluding to, that is mainly patients not in this kind of a, this is FONG risk is more than 2. If you look the FONG score is more than 2.
Correct.
And so it are all very high risk patients and they don't do that well with kind of studied liver mets. So kind of, and second thing is that now coming to the whether I will implement in my clinic or not. So actually this paper looks kind of very good actually. So I would like to wait for means more phase 3 data and more data coming up, the full paper coming up. But as per the results, am I happy or not? Definitely, it looks very good on the paper. But maybe a full paper, and then we can discuss to the patients. As of now, still I will wait a bit.
Okay.
Viraj, one point regarding that 42%. It is based upon 15 patients out of 36. If
Correct.
you take 15 out of the original 190, which they were screened and then they were segregated and then they found out, then that percentage becomes less. So when you discuss with the patient, we have to tell them the proper numbers.
Correct.
That selection is going to be very important because almost half of them were chopped out to begin with.
I completely agree, sir. I completely agree that with the denominator was 150 and we started dropping them a bit by bit. I completely agree. The only thing interesting for me with this strategy is there is no drug. Apart from MSI high, there is no drug that we have today in our arsenal which can have a potential to give such a survival for a 20 plus liver nodules in MCRC. That is all I'm just saying. So I agree. It has to be with caveat and it has to be done in a very high volume liver transplant hospital. I agree. Completely agree. I don't have one. So I won't be discussing this in my MDT. But if somebody has it, they should at least start discussing about it. Let's move on to the next study. This is orchestra study. Now, as a physician, we have this perception that, if you have 2 lung nodules, 1 liver nodule, 1 omental nodule in stage 4 colon cancer, you give them chemotherapy, and then if you get a good response, you try and debulk them. For years, I was practicing like that. I have referred many cases to surgeons like that, where you have 2 organs involved, but limited number of organ involved. So, stretching the boundaries of definition of oligometastasis, basically. So this study was basically answering that whether that strategy holds any ground or not. So Dr. Krupa, let me bring you in. So can you run us through how was this trial done and what did they find?
Yeah, Viraj. So I think this was in stark contrast to the Transmit study, which we discussed earlier. There, we're talking about tumor biology, selecting patients, highly selected population, like BRAF mutation obviously was excluded because we know they're quite aggressive by nature and they didn't want to include those patients because that would impact on their survival. But here you're looking at all comers and again looking at tumor debulking and probably just to highlight on the results as well. patients who had at least had more than 80% of resection, debulking.
So
Actually,
before that, can you comment about the patients that were included in this study? Like they are not like the TransMed study who would never go for resection. This was more of less disease. Would you agree with that?
yeah, so this was more like extrahepatic disease was allowed. And
Yes.
again, extrahepatic, at least more than 2 sites or 1 site with number of peritoneal diseases, mets as well were included. So that's how they looked at including these subset of patients. So obviously we're talking about 2 different subgroups of patients here.
Correct.
And you talk about more widespread metastasis here, not confined to the liver alone. So I think those are the key differences between trans.
But if you see the number of metastases column, less than 5. So that means 2 lung nodules, 2 liver nodules, 1 peritoneal nodule. Okay.
Correct.
Almost 40% or 35% were like that, which is, we might think that after chemotherapy, we may be tempted to take them out. Correct? I'm sure you must have referred such a case to your surgical colleague, right?
Very true, very true. As far as the volume disease was concerned, and when we talk about oligometastatic, we always talk about the number, site, and size of metastasis as well. We take into account all 3. So obviously, yes, there could be a role of local consolidative therapy. May not actually be surgery, but you could look at doing SBRT or any of that if they respond well. Again, I think the concept is that you pick up responders versus non-responders. So we have waste our time about when people are not going to be responders. But if you do have a good responder and biology of the disease is good, then you might want to consolidate with local therapy, be it in any form of the local therapy, be it ablation or, or any of those local form of therapies.
Correct. So Dr. Soumya, let me bring you in. Dr. Krupa was mentioning that these are not heavy volume diseases. These are not quote unquote oligomets, but not heavy volume, right? There's something in the middle where we go this way or that way. So let's say you have a patient with 2 liver nodules, 2 lung nodules, or 3 lung nodules, okay? Some point in time, you would offer them either surgery or surgery plus RFA or SBRT you pop in. And you can see in the intervention group, almost 70% of them did get what they were supposed to get. So do you do this in your practice?
Usually we take our decisions mostly upfront, but definitely when somebody is very young age, it's more of an emotional decision rather than sometimes kind of areas for young patient. It is, and then more enthusiasm, it disappears. This is the lung lesions or say liver lesions, and then we take a call that whether we should be pushing our surgeons to that area or our radiation oncologist to that SBRT to those nodules and not approachable by surgery. So it's more of a this trial again shows that means the decisions are not we are not getting the results that when the survival is increasing. Though the quality of life, they had a paper earlier, orchestra had a paper earlier also that the quality of life maintained post the local therapy. But when it comes to survival, it is not showing that impact. So it's kind of little bit step back to our more of emotional distance.
Amal sir, let me bring you in. Now, be specific in answering the question I'm going to ask you. You have 3 liver lesions and 3 lung lesions, right? This is a patient which is there in this study. You're giving them FOLFOX. Yes, this is included in this study. So now you give them FOLFOX. They have partial response. You're done with 4 months of oxaliplatin. Do you get an itch to burn them? Have you done that in your practice?
Yes, of course we do that in our practice. All of us do that. And I don't think so we should stop doing that based upon this trial, because this trial has missed the trick. And the trick is missed in the first slide. If you see if you can go to the first slide with the inclusion criteria, in which, go back to the first slide, please, if you can. 1 slide back.
No, this is the first slide.
Yes, here. So here, the treatment with 3 cycles of Capox and 4 cycles of FOLFOX, and then you do response evaluation. We don't do that in our practice. In our practice, if you do 3 cycles of Capox and patient is showing response or stable disease, we'll give another 3 cycles at least. we will get it further down. We'll probably get it to at least some partial response and then take him for local therapy. We don't stop at 3 and 4 cycles in a metastatic setting to begin with. And that is exactly where the trial has gone wrong. Because if the patient who is having a systemic disease, as you said, 3 liver mets and 4 lung mets, he is responding at the end of only 3 cycles, which I assume the patient has not got much toxicity at the end of 3 cycles only. I will give another 3 cycles. I will get it further down. And if I have done that, probably the trial would not have been negative. So I don't think so. This trial is probably going to help us not to refer to those patients who at the end of 6 to 8 cycles of Oxali, which most of our patients are able to take 6 cycles at least, or after that few more cycles of only bevacizumab and has those so-called good response, and the 3 out of 3 liver mets, 2 have disappeared, out of 4 lung mets, 3 have disappeared. So those patients can be taken because the trial, I don't know, I want to find out who is the peer of the trial, whether it's a medical oncologist, surgical oncologist, because that is where they have probably missed the trick. They had stopped it only after 3 or 4 cycles. That is too early to stop.
I completely agree with your point. But a flip point, an argument with that. The thing that we do means we still offer resection or SBRT or RFA to these patients is purely based on retrospective data, is purely based on single institutional practices.
Yes, yes.
So when,
yes.
Let me finish my question.
Yes.
Let me finish my question. So if such a study were to come, which is a randomized study, it's a prospective study, does it dent, at least put a thought? You remember we were doing primary tumor resections of colon long ago, not long ago, just 3-4 years back, when all the retrospective analyses and all the single institutional studies said that even if you have a non-obstructive primary, there was a sense in resecting them. And then again, the Asians came up with a randomized study and showed there is no difference. So what I'm saying is the practice that we've been doing for last 20-30 years is not based on any prospective randomized study. I agree with you that they did compromise systemic therapy. They should have given more, just like the Polo trial where they stopped in 4 months. I agree where you're coming from, but it doesn't make this trial null and void, right? So in that respect, what do you have to make? Where would you put this in your practice, or
So
you
what?
this trial?
So yeah. So if I had to put this trial into perspective, what I will say is that I will not offer local therapy only at the end of 3 or 4 cycles. Definitely, because this is what the trial has showed, that if you offer a local therapy at the end of 3 or 4 cycles, it is of no use. After further cycles, if the patient is having good biology, it is still showing response, then whether to offer local therapy or not, again, based only on the retrospective analysis, I may discuss. But what this trial tells me, don't do that at the end of 3 to 4 cycles, even the patient is responding, because they're not going to do well. Whether it answers the question, whether what happens at the end of 5 or 6 cycles, I don't know.
Sure. Okay. Point well taken. Dr. Krupa, do you, before we move on, do you agree with Amol sir's conclusion? Not offer.
So, the thing is, Viraj, so when we talk about liver-limited metastatic disease, we know only around 15% to 20% are going to present with resectable disease upfront. Majority of them are definitely going to be unresectable, right? So likewise here, horses for courses. I think, we are in the era of precision medicine, personalized treatment, and, doing what every individual wants. So I think, it has to be tailored according to the individual, according to their molecular biology as well. Here also, I don't see any reason as to why we could not have added targeted therapy here as well, along with the chemo. You could either do, either Cetux or bevacizumab.
Bev was there. Bev was there.
Exactly. Yeah, correct. But because that's what we routinely would do in practice as well. And, you could actually wait to see if we have a good response and then look at consolidating with therapy. Probably, yes, I would agree with Dr. Amol in that, we would have to give at least 6 cycles. And then if you have somebody who's still responding at the end of 6, then definitely yes, consolidate with local therapy. So I think that's my take on it. And again, the key thing probably that I wanted to highlight here is, again, if you're talking about tumor debulking, it has to be at least more than 80%. No point in doing a half patch or just for the sake of doing a debulking.
I agree. Great. Okay, let's move on. We have 10 minutes. Mathur Saab, how many minutes? 10 minutes? 15 minutes?
So 15 minutes, you can go
15
up
minutes.
to 8.5.
So we have 3 abstracts more. 1 immunotherapy for advanced, 1 immunotherapy for colon, 1 immunotherapy for rectum. So Dr. Soumya, let me bring you in. We have keynote 177, pembrolizumab first line, approved by NCCN. And now, do we need this? Why do we need this study? Or it is just another Me Too trial? What are your thoughts?
Yeah, so we had pembrolizumab, and now that this gives another armamentarium. So right now, so dostarlimab, nivolumab plus nivolumab. So and then we are opening up a gamut of options. Then CTLA-4 activity, we never knew that. So whether addition of the ipilimumab 1 milligram per kilogram per 4 does it make any impact? So, but already we have got pembrolizumab. So we had certain section of patients like say KRAS and NRAS or BRAF mutants, or somebody with a liver predominant metastasis. So in them, the MSI is high. Which of the immunotherapies will work better? So as we know from the other cancers, that all immunos doesn't work well. So definitely it did make sense that whether Nivo plus EP was doing much better than the Pembro, or it was comparatively lesser. And Nivo, as you already know, that the cost is also a bit different. So it does make a difference for the patient's perspective.
Dr. Krupa, let me bring you in. Here, one of the endpoint was a survival analysis on MSI by central testing, right? Why do you think they would have included that, specifically? Why would they want to test MSI centrally and not locally?
Yeah. So I think, Viraj, like we always say, we wish we had access to centralized testing as well, because then you would have uniformity in the reporting as well all across the country. So whereas, you send it to 2 different labs and you're likely to have 2 different reports as well. At least that's the state of, in India and where we practice as well. So that's definitely there in the real world. But the other key thing that I really wanted to look at was this dual primary endpoints. I'm never a huge fan of this dual primary. Co-primary is different because you're ending, you'll have to end up meeting both. Dual means you're settling for either one. So I think that's just one of those statistical designs, right? You're settling for either or. So rather than saying both. So co-primary for me would have been a better endpoint rather than saying this dual primary.
Very well said. Very well said. And just to further that, we don't have the second endpoint yet presented. They only presented one. Amol sir, let me bring you in. Let's not talk about the design. This is the graph of 8HW. This is the graph of 177. I had to actually overlap them, but I didn't. But let's see it again. This is for 8HW. This is for 177. Care to make any comments?
So,
Starting
you
off the
want me to
curves
talk
here,
good about
no
good things
crossing
about the trial. Yes. Okay. So let us understand. Let us talk good points about the trial. Yes, the trial, the curves are very well separated. The hazard ratio is 0.21, and there is a good enough crossover in the trial, almost more than 60%. And these are the plus points of the
65,
trial.
yeah.
But will it help me to decide whether 1 IO is good or 2 IOs are good? Because I already know from 2020 that pembrolizumab is a single agent is approved. And now I have a 5-year data that it is better than chemotherapy. Now, what I want to know is that whether Nivo plus EP is better than a single agent Pembro. And that answer I have not yet received, because the arm with which Nivo EP versus Nivo, the results are out. And that is why then other question that I would like to see when the full paper comes is that because
sir, let me interrupt you. Just on that point,
yes.
I agree with you. We are waiting for monotherapy data, but I know you are a very good statistician.
Yes.
You read between the lines. Now, can we use our mechanics here and tell me whether this is better or this is better?
Okay, so get back to the previous curve. I will tell you. Get to the Nivo EP curve. So if you see here, they have taken 171 patients. When they begin with 202, that means almost 30 patients were chopped off because the central confirmation of the MSI was not done.
Correct.
Now,
Correct.
if you go to the first slide of all the three arms, and if you see here, the entire trial, you have not put that number here, is around 800 patients, out
Right.
of which this is only 202 patients data. So we don't know whether all the three arms are equally powered. And as Dr. Krupal has said, we are looking at a dual primary endpoints, in which one endpoint is only for first line setting, another endpoint is across all lines. So whether all this, because we are looking only at 25% of the total patients included in the trial. 108 patients, we are data of 202, and whether this is sufficiently powered for individual arm, that we don't know yet. So I will like to see the publication, then I will like to comment whether that particular curve that they are showing is really praiseworthy. But prima facie looking at it, I'm happy I told you to begin with only that there is a good crossover, hazard ratio is 0.21, but I have my reasons why it is 30% patients are gone, and out of 800, it is only 202 patients data.
Okay.
So if we purely look at this also, there are statistical questions.
Okay.
And regarding my clinical practice, I told you, it doesn't help me to answer whether I need to give 2 IOs or 1 IO because I don't have the comparison.
Okay. So Dr. Soumya, let me bring you in. So you see the blue curve is Pembro alone, and you see about 30% of patients actually do worse than giving chemo plus target, right? Because those were the PDs. So how do you identify what do you think they are? Why are we facing that? And we are not facing such a phenomenon here, right? Less than 10% had early PDs. Okay, don't go. So the numbers say less than 10% have PD, early PD. Here, around 30% have early PD. So why do you think they are? Who are these patients who don't do well on checkpoint blockade?
So some patients who are having a high burden of liver mets, and so they sometimes they don't do well. And pseudo progression, I think that it is still not much. We have not seen much, but definitely it might be still there. Regarding low TMB, of course, we have data from other trials as well. They don't do as well as compared to a high TMB. So probably these are the patients who might be doing worse, even despite IO.
Right.
So Viraj, let me add that point. That what I will like to see from this trial is that whether the double IO combination does well in liver mets. If that particular data, they have shown that in one of the forest plots, but I would like to see those numbers in detail, that how many patients with liver mets, how many of them actually got CR. So if that data is good enough, then maybe in my practice, I will see that probably those patients with predominant liver mets, we may go for 2 IOs with this limited data, whatever it is. But again, the toxicity also have to be taken into consideration, which I assume you will discuss.
Right. Dr. Krupa, let me bring you in. Why do you think we have such a phenomenon where patients with liver metastasis, this is on the right, we have a Mayo experience. They had about 40 cases, and you see all the yellow bars had liver metastasis. Majority of them don't do well, or despite being deficient MMR, on single agent immunotherapy. What do you think is cooking here?
Yeah, absolutely, Viraj. So I think, we've had this, even if you look at the dostarlimab study as well, I think, majority of them also were TMB high, which is why you're getting to see 100% CRs. So, the concordance between MSA and TMB, if I were to put it that way, is only around 2/3. So we know the concordance is not 100%. So if you have somebody with an MSI high and a low TMB, then definitely, yes, they're not going to respond as well, which is where those early progressors come in. And to me, to the naked eye, just looking at those two curves that you put up, the Keynote 177 and this Nivo EP Checkmate 9 HW curve. So I mean, like for me, the curves cross over and there's no early separation of the curves. In fact, if you look at the Keynote 177 data, and the hazards are not as impressive. So just from a layperson, if I were to look at it just as a layperson, I would say that the Nivo EP curves are definitely much more, should I put it this way, they're much more glamorous and probably look much better for me to the naked eye. So, I think that's one way of looking at it. Again, all the points that you've rightly put up as well. Wrong misdiagnosis.
Let me confuse you more. Just hold on to your thought about concordance between MSI high and TMB. So this is what me and Anant always talk. That people who don't do well on immunotherapy who are MSI high, pakka they would be low TMB. Okay. So we were always about this. Now, 2 days back, we had an OBTO with Dr. Rameshwaram, and we did discuss this niche 2 study, right? The Chalab study. In that, they had taken NGS for all. And surprisingly, 4 patients out of them had low TMB, and they all did CR. Okay. So, do you think early cancer TMB does not play a role? Advanced cancer TMB has a role in relation to MSI. What do you think is happening? How can we evaluate this? Also, let me come to you. Let Dr. Krupa, shed light on this.
So absolutely, Viraj. So I think, we've always had this, right? I mean, like when the primary tumor is intact and the tumor microenvironment being better, so, more conducive to immune checkpoint blockade.
Yeah.
So that's one of the reasons that I can think of, number one.
Absolutely.
And then, like you rightly said, apart from MSI and TMB, we're talking about TILs, TAMs, T-regulatory cells, and then again, the alternate pathways like LAG3, TIM3, TIGIT, VISTA, IDO, you name it. And, so there are so many other alternate pathways or mechanisms of resistance that we still do not yet understand. Absolutely, yes. And again, the tumor microenvironment also is about making it more conducive with dual blockade, and not only that, about adding VEGF blockade as well. So we all know that, and that's probably one of the reasons as to why we get to see these subset of patients not doing as well. Right?
Yeah. So one of the studies that was from Tempest, and it was presented a couple of years in ASCO as a poster, where they checked 4,000 patients NGS data for colorectal cases, where they had liver metastasis, lung metastasis, peritoneal metastasis, and they thought that the NGS would be different, and they were wrong. All three, whatever the site of metastasis is, the mutation profiling was identical. But what was different was that patients who had liver metastasis had very less TILs, what you just mentioned, and high macrophages, which they are not conducive for immunotherapy. While patients who have lung-only metastasis, they have very low macrophages and high B-cell infiltration. So perhaps that is what microenvironment is playing bigger role in advanced cases, advanced MCRC cases, vis-a-vis early cancer cases. Amol sir, what are your last thoughts before we move on to the next paper?
So basically, there are 2 questions. Why those with the liver mets don't do well as far as response to the IO is concerned. And we all know that once you go inside the liver from the colon, the cells cancer cells get additional protective mechanisms. They have additional immune invasive mechanisms. And I sometimes tell in my layman lecture is that once the thief has ran away to Dubai, you can't catch him. So it's like if as long as you're in Mumbai, you can be caught. But once you go to Dubai, it is difficult for you to be caught. So probably liver is like the Dubai. That's one thing. Second thing, whether the TMB and MSI, what is the correlation? So a lot of speakers have said that the TMB is not that a great marker because it is not just the total mutational burden. It is what kind of mutations are there. So you may have a low TMB, but you have a good MSI-related mutations in them, and the patient may respond. And you may have, generally, if you have high MSI, you will have high TMB. But if you have low TMB, does not mean that you are not going to have those mutations who are going to show response to IO. So generally, we will like to look at the MSI rather than the TMB, and the TMB low with a good MSI, whatever the MSI-related mutations, that patient may still respond. And that is what has happened, that 4 patients have responded.
Okay, last question, be specific. This is Keynote 177 forest plot, which says KRAS mutant, probably there is a harm. And this is 8HW, where they said whatever mutation, it is okay. Question to you. Is this a spurious forest plot? Are we reading too much? Or adding CTLA negates what is bad about monotherapy? Short answer, Amol sir.
So this particular forest plots where there is no p-value of interaction given, I'm not so sure how to read that. They have to give the p-value of interaction on.
Come on, Amol sir, this is so much on the left.
No. Let me come to that. So I would like to have the p-value of interaction, even though it is obvious. That is the first thing. Second thing, now here, if you see the trial design, And if that particular slide, if you see, the choice of targeted therapy was not by compulsion. They said that may give bevacizumab, may give cetuximab.
Okay.
So we would like to see how many of the control arms have really got the adequate targeted therapy as the site deadness and as per the mutation burden, and hence that difference, that so everything on the left, that may be because the control arm is not performing that well, because the control arm is not probably received the required targeted drug as per the sidedness and as per the mutation status. So that is why I said we have to look at the full publication before we can comment on this.
Okay.
And
All right. Dr. Soumya, short answer. Spurious forest plot, or do you think adding dual makes sense?
It has been there from right from the starting. That keynote 177, when we saw the KRAS and the NRAS, they were not doing well. The Nivo plus EP is doing well. On the surface, it looks that for when a patient comes KRAS NRAS mutant, then they do well with the Nivo plus EP. So regarding the full paper publication, waiting for the full paper.
So if you have KRAS mutant, MSI high, what will you give? My question.
So if KRAS is mutant and MSI is high, then probably still now I'll give a Pembro till the paper comes.
Dr. Krupa?
Yeah, Viraj, so I just have a slightly different take. I mean, like, see, the thing is, in lung cancer, when we talk about co-mutations as well, right? Even when a KRAS, you have STK11 or KEAP1, we know they are immunologically slightly colder tumors because of the STING pathway being activated. So thereby, your IO plus IO combination actually helps overcome that. And that's something that we've seen even from lung cancer. I'm just
a short answer, Dr. Krupa. KRAS mutant, MSI high, dual versus mono.
For me, for a KRAS mutated, I would definitely go with the dual Nivo plus CP for me.
Okay, great. Okay, let's move on. We have 5 minutes. So this is Dr. Sarsek's paper. Initially, after 12 patients, it was there in NCCN, dostarlimab for 6 months. And 12 patients had complete response, and for 2 years there was no relapse. Question, 2 questions only for this study. Amol sir, we typically use dual IHC loss as a MSI high or a deficient MMR. Although by definition, mono loss is also okay. In this study, Dr. Sarsek's study, if you see 10 plus 10 plus 6, out of 48, 26 patients had a solitary loss of IHC, right? That's a lot of mono loss. What do you think of this? Like, how do you interpret this? 5 plus 5 plus 3, sorry, 13 out of 48. 13 out of 48. So quarter of patients had a mono loss.
See, this is a highly selected population. This is not a randomized trial. So we don't know how many they have screened and how many they have chosen.
No.
So
I'm just saying,
we cannot comment on that.
So, okay, let me flip the question. If you have a mono loss, would you consider it DMMR or would want to double check with PCR? Straightforward question.
I will like to check with PCR, but if my pathologist is IHC is good enough and is trustworthy, then I may.
No, the best pathologist, sir. Best pathologist.
I will start the treatment and I will check with the PCR because PCR may take time.
Okay. Dr. Soumya, if you have a mono loss, would you check?
Yeah, I do check for the mono loss because they don't do as well as others. So that's why I do check them.
Okay, Dr. Krupa, can you shed light why should one or should not recheck with PCR, which is gold standard for MSI, if you have a solitary loss of IHC?
Absolutely. So, just quickly there, and I'll tell you, see, for example, MLH1 and PMS2 pair with each other, and MSH2 and 6 go hand in hand with each other. So if you have somebody with only an MLH1 loss, the next step of the algorithm would be to check for a BRAF V600E. And if that's also not there, then you go on and check for MLH1 promoter methylation.
Strangely, they didn't have any solitary MLH1 loss.
Absolutely. So, that's probably one bit surprising there, but nevertheless.
That's what I said. It is super selected. They probably, we don't know the denominator, how many they have checked and how many they have taken.
Correct. But if I remember right, I think, 30%, close to 30% had Lynch syndrome, HNPCC. Yeah, close to 30% had HNPCC. So that means they have gone ahead and done a germline.
50%.
Yeah. So, so close to 50% of the population. I mean, like you're talking about close to 50% having a HNPCC. So which tells us that probably germline testing also, if you go by the algorithm, should be offered in those subset of patients. So I think, for me, you have to go with the algorithm. I won't just be sticking to just one monoallelic loss. I would definitely look.
Perfect. So that is what I do. And that's the message. If you have one loss of IHC, you're better off confirming with your PCR. Okay, now last question before we move on next. Amol sir, if you are performing this strategy in your rectal cancer patient, when would you evaluate? And most likely 2 months or 3 months. And at that time, if you don't get CCR, how would you proceed?
So again, this has to be done in a center where the backup team is excellent, the GI surgeons and the endoscopists and the radiologists.
You have the best team.
So if I have the best team and if I don't get a good results at the end of the 2 to 3 months, then probably will be keen to pursue the strategy. I will go to the conventional strategy.
So what is good result? What is good result?
I should get the CCR. Now the problem is that at least I should get a PR at the end of 3 months. CCR I may not get in 3 months.
Correct.
So if you're getting PR, then okay, fine, continue. Because if you see the swimmers plot, a lot of people have continued and got a good response. But in 3-4 months, you should get to know whether in which direction we're going. You're going in the right direction. If the train is going in the right direction, don't get out. If the train is not going in the right direction, pull the chain.
So that's a very nice message that as long as the tumor is shrinking, you might not get a CCR at the end of 3 months. As you can see in the swimmers plot, only 6 out of 42 patients actually had a CCR. Majority of them achieved CCR at 6 months and almost 6 other achieved at 8 months, 8 to 9 months. So that's an important message. Why I'm telling you this is there was one case where I was discussing with one of my fellow oncologists and a surgeon operated with 3 doses of Pembro because it was not a CR. There was a tumor shrinkage and it was a mucinous tumor. So there was no response seen on an MRI. And unfortunately, this boy got an APR and it was TRG1. There was cancer found. It was not a PAT CR, but wish if we knew this strategy, this patient would have avoided stoma. Organizers, do we have 2 to 5 minutes before I close, or do you want me to close?
Last 5 minutes, sir. We can
last
have
5 minutes. Thank you so much. So this is a NeoPrism study. Now the similar strategy, but for colon cancer. Now in colon cancer, we are not worried about stoma. So
yes, that is important.
Amol, so why do we need to do this study? We don't have to avoid stoma. Why do you want to do this study? In fact, there are 4 such studies.
Yes, there are 4 such studies, and they have shown there is a good PAT CR.
Yeah, but why? So, why would one want to do this?
Unless and until this strategy improves the OS in the long term in a colon cancer, I don't know whether this will have a long-term role in the clinical trials. So we would like to have, of course, the randomized trial. These are only phase 2 trials. We'd like to have phase 3 trial, randomization, and see whether ultimately this leads to an OS. Because as rightly said, in colon, we are not worried about saving the sphincter, which is there in the rectum. So it is a good strategy. It is something to look forward, but it is still not yet practice changing as of now, unless we have a larger phase 3 data.
Okay. Dr. Krupa. So, if we see the Foxtrot trial, where we use neoadjuvant FOLFOX and then operation, there were T3s and T4s in that patient, specifically T4s. I want to talk about the response rate of chemotherapy for deficient MMR patients in the Foxtrot was 7%. Okay, it was 7%. So now tomorrow you have a large hepatic flexure mass, which is how they present MSI high variants, which is encompassing the pancreas and stomach, and it's a large mass, and it's deficient MMR. How would you manage this patient? And surgeon says, I can operate this, but it would require a multivisceral resection. Dr. Krupa, do we have you?
I think Krupa is not there.
Okay, Dr. Soumya, can you take that? How would you manage this patient?
I have had some bad experiences with MSI high. They don't respond well to chemotherapy, and they have a
Respond
high
well.
rate of relapse. They don't respond well. They don't respond well. So for
No, he said did not well.
Correct. So that's what the Foxtrot showed. 7%. Means
Yeah,
somebody.
they
Yeah.
respond. So the problem with them is that once they relapse, then probably it's very bad news, and they are mostly in young patients. So that's the reason that these trials are very important for all of us. These are early days, but definitely they are very important for this set of population.
So, Amol sir, this is my take, and you can correct me whether I'm right or wrong. I agree with you. A T3N0 colon cancer does not require any, which is MSI high, does not require any other treatment apart from surgery. No chemo, no IO, nothing. They are just cured. So this was a study, and other 4, which I just mentioned, like the niche and the Asian Sintilimab
Yeah,
study. Each study actually specified that they want the T4s and the high-risk T3s, right? How confident are we in our radiologists? Like in rectum, we have evolved since last 15 years by doing MRI for local staging. For colon, we still rely on CT. If we were to pursue this strategy, do you think doing MRI for MSI high colon cancers would be a future thing, or we have to do that and make sure that we only offer these strategies to the bad stage 2s and 3s and not the T3 and 0s, where you said that they will be cured anyways with surgery?
So technically, we'll have to see whether the trials that have been done, have they done the MRI to find out T4N1?
They did not.
Probably not. They did not.
No.
So if the trial themselves have not done that, to do that in the real world is probably asking too much. But I agree with the point that in a bad disease, in the disease in which you have, say, as you described, a hepatic flexure mass and difficult to resect, one may do that. What I will like to see in future is that whether, as you give an example, that if you give the highly aggressive chemotherapy, Foxtrot, and there are 7% response, whether that can be improved by adding Foxtrot plus IO. And that is what I will like to see in the future.
That's already ongoing. That's the commit study.
Yeah.
That's the commit study.
Yeah. So that's what we'd like to see. And ultimately, of course, we'll require a randomized trial for it to become a standard of care.
So the commit study that you're mentioning is IO versus IO plus chemo. But I agree with you, nobody would do a study of IO versus chemo in MSI high ever from now onwards.
Correct.
So that's a done deal. Some form of IO has. Now, interesting point here, Dr. Soumya, is that, you know, the hypothesis was about 30% of patients would have low TMB. And in them, they would only get 1 dose and straight surgery. Well, if they have high TMB, they'll get 2 more doses of pembro and then surgery.
Correct.
Why would they think that 30% of early colon cancer would have a low TMB? And in reality, in fact, there was only 1 patient, actually.
1 patient. That is the problem.
Yeah. No, the problem was in their hypothesis. What was wrong with them? Why would they think that 30% of early colon MSI high would be TMB low? Nevertheless, so this was a false assumption. And because of that, the whole statistics got messed up. But Dr. Soumya, do you want to make a comment on this waterfall graph? Is this like the Chalabi plot? Or this is something like different? Chalabi used dual IO. This is early tumor where we are contemplating dual versus mono. So what are your thoughts?
So the PCR in the neoprism study, it is around 60%. So most of the other neoadjuvants, the problem is that the number of patients are very less in all the neoadjuvant colon trials, and the PCR is something like around 60 to 70%. That's how it looks like. Not
only
unlike
3 doses, no? Only 3 doses given.
Only 3 doses, yes.
Yeah.
But the PCR looks good on the.
So if we would have given them 9 cycles, okay, like dostarlimab, okay, so that means proper 6 months. What would you think would be number of PATs here? Just give me an educated guess.
70%.
If we give 9 cycles,
we don't know.
at 6 months, and do surgery at 6 months.
Rectum might be a bit different from colon. That's the reason that I'm telling you.
Okay, interesting. Amol sir, so be specific to this answer. For colon cancer, I'm giving 9 cycles pembro and operating them at 6 months. What do you think would be PAT-CR rate?
It will still not be like the Chalabi trial because rectum is different from colon.
You mean the
And
subset?
yes, you will have. Yeah. So basically, yes, you will get more the PAT-CR or
How
the
much?
CCR if you
How
increase the
much?
duration, and it will be a wild guess, anything above 70-80%. But whether we'll get 100% by chasing it up to 8 cycles, 9, 10 cycles, we don't know. Rectum is probably a different biology than the colon. And
What makes
let
you
us
say
wait
that?
for.
What makes you say rectum and colon have different biology? Because none of the NGS studies have shown us that. So rectum and sigmoid
Because if you see,
identical.
if you see,
Identical.
if you see,
Yes.
yeah, probably those who are low rectal tumors below the peritoneal reflections, whether they have that immune sensitive, more immune sensitive as compared to the other, we don't know. And if you see all the 4 trials that you have mentioned about the neoadjuvant IO in the localized MSI, they have very clearly mentioned the number of patients with colon cancer, rectal cancers, and probably to look into the data that whether the rectal tumors are done better as compared to the colon. But my gut feeling is that probably the rectum will do better as compared to colon with the same drug and the same duration. But I may be wrong. We'll have to see the data.
Okay, I got a
Dr.
message.
Viraj, can we close now? I mean,
I
it's been
just
a
read
bit
your
of-
message. I just read
Oh,
your
Vamshi has landed. Vamshi has landed finally. We are happy. We were worried whether the Vamshi's plane will land or not. But
It is Mumbai.
So,
It is your city, Dr. Mul.
thank you, Dr.
Unfortunately, your
Vamshi.
city's traffic is.
Yeah, thank you, Dr.
Yes.
Vamshi, and thank you, panelists. We had an excellent discussion.
Thank you. Yes.
Dr. Vamshi, I
Thanks.
hope we did like on-client peer exchange, which you wanted us to do. And
I'm very happy. The 10 minutes that I heard was excellent.
Okay,
Thank you.
so I hand it over to you. Thank you, Amol sir, and thank you, Dr. Chinmay.
Thank you.
So, Arun, can we have the next session, please, by Dr. Shiva, if you can introduce him?
Yeah, so thank you. So thank you. Welcome, Dr. Vamshi, sir.
Okay, Dr. Viraj and then Dr. Krupa is there.
Yes, sir, is there.
Krupa?
Dr. Kripa, sir.
Perfect. Fantastic. Can
Yeah.
you start my share screening, please? All right. So, last session, we'll do it quickly because, to be honest, next slide, please. The most important thing that we have been discussing has been the first-line management and the immunotherapy. So, how do you decide that in 2024? That's what it's all about. Next slide. So, this was the paper, Nivo EP, the checkpoint VW. Next slide. And as you can see, some important points to note. Next slide. Most importantly, if you look at the design of the study, you have the initial group excluding BP4. Otherwise, all were included. CPS 5 or 6, no B7. Then giving Nivo 1 EP3 for up to 4 cycles, followed by Nivo. Right? That's the general thing. And of course, the comparator arm was very interesting. They said we could allow either lenvatinib or sorafenib. So that's a little different from usual style. So Viraj, if I can ask you quickly, how often do we see this group of population? No VP4, only CPS 5 and 6 in clinical practice.
So majority of our advanced HCC actually either have Child-Pugh B or they'll end up having a main portal vein thrombus. So if you want to put me a number, only about 2/3 of patients would actually be eligible for the study. And
2/3, that's actually a very big number. I would actually have thought 50%. So 2/3 is actually a bigger number than I would have thought. But great. So again, the reason I'm putting this out is for everybody who is listening, you cannot view the same, the numbers. The numbers which we are putting
your
here,
voice is breaking.
Okay, I am actually there outside. I don't know, the network may be a little bad or a little patchy.
Okay.
Is it any better now?
Yes, better.
Okay, perfect. So what I was saying is these are the numbers that we normally see. And of course, not all our patients walking into OPD will be fit for all these trials. That's the point I wanted to make. Next slide. When you look at the PFS, it's the same. Nivo EP has that thing. Nivo EP has done that. We have the same PFS. Next slide. Look at the overall survival. It's better.
The curves cross. Dr. Amol keeps talking about the curves which kiss and cross. These are crossing curves. Kripa, look at these curves. PFS, the same. OS, different with crossing curves. How do you look at that?
Yeah, Vamshi. So I think, to me, the surprising point is look at the control arm, 20 months, with
Correct.
the sorafenib and lenvatinib alone. So again, that also probably tells us that the patient selection probably here as well. I mean, like they probably selected a very good subset of patients where you're getting around 20 months of survival even with the sorafenib or lenvatinib. And again, the curves crossing over that, I think, we just had the discussion in the keynote 177 as well.
Correct.
There,
Correct.
so that seems to be the all IO drugs, we get to see a delayed separation of the curve, the tail of the curve as well. So I probably put it down as, probably to account for the sort of progression as well. And then you get, that's why no PFS benefit as well, 9 versus 9 months PFS, but overall survival is to see a slight difference at 23 versus 20 months.
Viraj, we had the LEAP negative trial on headline, but lenvatinib arm there had 20 months survival. This trial has allowed you lenvatinib or sorafenib, it's 20 months survival. So, is it just that all the trials have shown a benefit because the comparator arm was sorafenib? What do you say to that?
So 2 points. First point, in this almost 80+% on the control arm was lenvatinib. So it was lenva or sora, but majority of them got lenva. So this proves the point that lenva monotherapy, like you mentioned in LEAP 002, and now this checkmate 9, lenva alone also gives you a control arm of 19 to 20 months. So that is point number 1. Point number 2, because of that, you see the benefit of IO, incremental of IO, dampened, in this case 23, and in pembrolizumab it was 21. And if you see the newer generation of trials, especially pembrolizumab in this one, almost 60% of patients on the control arm would get some form of immunotherapy later. So that's why we are not able to see the wide separation of overall survival like we seen in Atezo-Bev study. Because back in 2017, not many people actually crossed over in the control arm to Nivo monotherapy, which was standard back then.
This was 35% in the crossover actually. 35% got immunotherapy. So,
sorry, one third.
I don't know.
One third. Yeah, 1/3 of patients, which is still very high as compared to what you would see in Atezo-Bev.
Perfect. So next slide, please. So let's just, put it. This is again a subgroup analysis. Viraj, we have been talking about this. Non-viral subset is again negative. Again, we have spoken about it in every trial. The nature of study showed. Our ImmuHub did not show this. We did see a benefit even in the non-virals. Should you treat non-viral differently?
Yes.
Or are you treating it same? Yes. Okay. Emphatic answer. Kripa.
So no. We don't treat them separately because I wanted to make a point on this. So, all the hypothesis which was generating over last 2 years was based on the post hoc analysis. Only 2 studies actually made a pre-specified subgroup analysis. One was Himalaya and one was this one, Checkmate 90. Both of the trials where prospectively you pre-specified the subgroups, both of them showed that it does not matter whatever your etiology was, IO is better than TKI. Now, one can also take a flip side to this and said, boss, this is the only 2 trial which included CTLA-4 along with your PD-1s and high dose of CTLA, and rest all the hypotheses that we've been doing post-hoc analysis were monotherapy. So 2 things can be concluded. One, that there is nothing to do with etiology, or even if it is, adding CTLA negates your bad NASH. So if tomorrow I have a non-viral etiology, I would be tempted to use a dual IO if at all I'm using IO as a strategy.
Kripa, your take on this.
Yeah, I think, probably I'd agree there. But, for me, the key question is, would I just do the STRIDE regimen, which is just a single dose of tremelimumab with the regular interval dosing of durvalumab, which we call the CTLA-4 priming, where you're priming the T cells to act better. So probably just 1 dose is good enough. Then do you actually need 4 doses? I'd agree probably in that you using an IO plus IO, especially if it's a non-viral etiology, would probably be yes, definitely yes. But then, do you need all the doses, or probably just even a single dose of tremelimumab should be good enough? I think that's an open question.
Absolutely. And again, I3, remember this is not I1. I1 we know can be easier managed. I3 is a little more difficult. So
Sure.
this I tend to agree with both of you. I mean, at my heart, I know that I don't have a very strong evidence in the non-viral, but still I think it is still better than not giving anything, than not giving IO. I mean, anyway, in the second line, you're going to give IO. We don't have anything to say that second line IO doesn't work in non-viral. So in that scenario, you might as well use it in the first. That's how I take it. Viraj, you were saying something?
No, I
Okay,
agree
sorry.
with you. So we should, IO
Right.
should be given.
Should be given. Agree. Next slide. Right. This was the adverse events. Look at the adverse events. 25%. 25% grade 3, grade 4. And I thought it is hypothyroid grade 3 in a trial. That is why it is high. 12% hepatitis. It is a concern. Viraj.
Yeah, so that is a big concern that despite there were no child QB, you have 15% of grade 3 for hepatitis. We both have
That's
gone.
exactly what
I know.
Yeah.
This is scary.
Yeah.
This is
It is scary. And
Yeah.
it is scary. 1 in 10, 1 in 4 is going to have a discontinuation. It's not easy.
Yeah.
Right. Yeah. Next slide.
That is the problem with high dose CTLA, using 3 mg per kg EP. And, I was part of the Emerald 3 where we were giving 300 milligrams of Tremi. It was scary.
Right. So this is where we are. We are talking of 3 different trials. Next slide, please. So, catching the bull by the horns. This is the data. 4 trials. You have the lenvatinib. I have not put the checkmate here. But even if you include the checkmate and add it to this, the only study which has actually shown you PFS and OS is the IM Brave. Your Himalaya did not show a PFS, showed only OS. Your checkmate 90W shows you only a OS and not a PFS. So Amol Akhade sir is asking us, which is better of the 3? And number 4, Lenva Pembro. Still look at it. It has a 21-month survival. So would you be tempted to use Lenva Pembro or would you stick to Etizobev? I mean, this is not a sponsored session, so all of you can answer freely. Kripa, I'll start with you.
Yeah,
Supposing
sure.
you get the stride protocol, you have the stride suit, you have Ipinivo available in India, and you have the Etizobev. What would you use?
Yeah, so just to add one more thing to the mix. So the CARES 310 data as well.
That's coming next. But CARES I did not keep because it's not available with us, so we can always ignore it.
Agreed. But if you look at it just in terms of overall survival, there also you're going beyond the 2. I mean, close to 2 years, 22 months versus 15 months. So they're also pretty impressive overall survival benefit. But for some reason, whatever the IO plus TKI combinations haven't done well. If you look at it across the board, be it either the Kebo atezolizumab or the pembrolizumab, they were not positive trials. I mean, obviously there were a lot of statistical flaws as well, because looking at whether only PFS advantage, none of them did translate into an overall survival benefit as well. So, to me, as of right now, with the longest, follow-up and survival data, atezobev seems to be the way to go forward. I mean, maybe moving forward, when we do have access to camrelizumab plus apatinib or rivaroxaban, which is the next data which we're going to discuss as well, that is probably promising to me as well. But as of right now, I think atezobev for me. And if somebody is not eligible to go on to BEV, is where I would look at doing the IO plus IO combination. So for any reason, be it varices, bleeding, any of those reasons as to why they're becoming ineligible for bevacizumab, then I would probably look at doing an IO plus IO.
Perfect. I think, Viraj, this is where we will not say one is better. We just say look at the situation. If you can give Etizobev, give Etizobev. You can't give Etizobev, no problem. Give a stride. Or even Durva monotherapy, there is data which is not bad. By the Durva monotherapy is accepted by NCCN in the second line, as a monotherapy. So for whatever it is worth. So Viraj, do you agree with this, or would you say no? This is the best.
I agree. The default would be Etizobev for majority of us. But in 2 scenarios, one, what Dr. Krupa said, if you have a VEGF contraindication, and second is perhaps now I'm tilting towards, after this checkmate 9, there is something with CTLA and NASH. So tomorrow, if there is a NASH related HCC, I would use dual IO as compared to Etizobev. Otherwise,
Absolutely, I agree. I mean, I would be tempted to use I1 and N3. I'm not sure if I would be brave enough to use up to 4 cycles of I3, but yeah, that's, I think, the way to go forward. So all these data are interesting. I find the fact that we are discussing IO and HCC so much in medical oncology conference, that itself is a huge progress. So next slide. This was the care study. Yeah, so subsets is what we'll all be. The next slide, please. So the next slide is about the care study, which was right. This is the ImmuHep we had discussed already. The ImmuHep showed in Indian patients similar results as to the Atezo-Bev. Next slide. So this was the study camrelizumab and rivorucinib, and I think Krupa is much better than me at pronouncing these names. I simply cannot pronounce them. He was able to do it in a flash. This was the CARES 310 study. Again, look at the OS. The hazard ratio is 0.64. Median OS rate is 49% at 49 versus 36 at 24 months. Look at the median OS. Again, very impressive results. So this is one more. So next slide. So this is what you were saying, Kripa. Should we have a magical duo, the awesome twosome? You use any one of these, Pembro, Nivo, Etizo, whatever you want, any PD1, PD-L1. And on the other side, maybe not a TKI, but use a VEGF or a CTLA. So is this where we are going to go to? Kripa, your thoughts?
Yeah. Absolutely, Vamshi. I think you hit the nail on the head. And as far as the pronunciation is concerned, I think probably apatinib sounds easier to pronounce because that's how rivoceranib was actually called earlier. So I think that's.
Oh, I see. So apatinib is the rivoceranib.
Yeah,
Okay,
correct,
I did not know that.
correct.
I was not aware of that. Okay.
Yeah.
Okay, I thought apatinib is still different. Fair enough.
So
yeah,
I
Viraj,
think
yeah, go ahead.
Yeah, so like you rightly put here, Ramji, I think, I agreed. We're in the era of combinations. I think combinations are here to stay. I think it's no longer just a single agent alone. So either IO plus VEGF inhibition or IO plus IO.
Perfect. Viraj, your thought. IO plus IO or IO plus VEGF?
So I call all of this basket as one, all of this basket as one. You should add one from each side.
One from each. I think that's where even I am slowly going to. And only question is, when in the future we get TCL in India, we get other Sinti or something, then should we add one of those or should we just stick to the guideline? I think there is no right answer to that. Right. Next slide. So I will not spend too much time on the other things. I think this was what I really wanted to discuss. Emerald 1, adjuvant. Are we doing it? Viraj, have we started doing it? Offering it at least.
Offering, yes, not done yet.
Not doing. All right. Next slide. So the I am brave is next slide. I am brave is something I have offered to a patient because large volume disease with some PNI and all. So we have done it for one patient, but this is, I think, where the future is going to shift into. Combination of taste, IO, I think that's where everything's going to go into future. So I will not waste more time on this because I think we have covered. I just wanted to bring in the fact that we have a lot of IO and in HCC now, and the way forward is an IO plus a combination. IO plus VEGF seems to be the best bets. So next slide. Next slide. This was what I really wanted to ask. CAR-T in HCC. Viraj, excited?
Very excited. I think so. In next 10 years, we will have CAR-T for all solids.
CAR-T.
So this year we had CAR-T for colon also, which was targeting the CEA. Yes. Here they are targeting the GPC3. This and I don't know whether we are discussing this, but out of 20 patients, they were all multiply treated, and all of them got IO in their lines, and 50% of them had ORR. And 90% of them had tumor shrinkage, just like the ALL story. So very.
So the beauty of this story, Viraj, in ALL and lymphoma at least, the response is calculated at day 28 in lymphomas. I do not know what they do in. I really don't know what they do it in
6 to 8 weeks.
This thing.
6 to 8.
It's 6 to 8 weeks. That makes more sense at least. To 28-day lymphoma is a shocker for me. And again, the more we see lymphomas, well, CAR-Ts, they do relapse. It's not as great a story as we would sometimes think. But anyway, that's a personal opinion. We'll see how it goes. So I think that's about it. Next slide, please. And thank you both the panelists for a wonderful discussion. I think it was a crisp and short discussion, but we have covered everything important. Viraj and Kripa, anything either of you want to add? Otherwise, we'll wrap up the sessions.
Thank you.
Okay. Thank you, both of you. And thanks to all the listeners. Thanks to Horizon and Tarun.
Yeah. So
thanks to all
thank
the
you so very
sponsors.
much, Dr. Vamshi sir. Dr. Vamshi, would you like to have a very quick recap of yesterday and today, maybe in a minute or two? And so that we say good
So,
night. Yeah.
Okay, quick recap would be basically we had very good discussions on the ASCO studies, and I'm happy that all the moderators put in a good effort to discuss only the important studies. And there's a lot of discussion on how we are going to integrate it into our routine practice. Esophagogastric immunotherapy is again the way. Would you use it in the first line? How do you integrate it into your adjuvant therapy and perioperative? I think esophagogastric is where we are going into that. Then we have the second sessions, which were all on the pancreaticobiliary. Unfortunately, not too much happening. How much ever we try to use immuno, not really responding well. Molecular diagnostics, ctDNA is the story. Today we discuss HCC, where the flavor of the season is again immunotherapy. Colorectal, again MSI high, colorectal, MSI, and again we are discussing neoadjuvant immuno. So willy-nilly, whether you like it or not, IO seems to be everywhere. So that's all about the ASCO deep dive. And I thank organizers and I thank the sponsors for supporting us. Good night, everyone.
Thank you. Thank you so very much from the organizing team, Aram, my colleagues, and Nishan. Thank you so much, Dr. Vamshi, for giving this opportunity. Stay safe, stay blessed till we meet again. Good night, everyone.